Mandy, welcome.
Thank you. Thank you guys for inviting me to speak to you today. So I'll start off with a couple of disclaimers. I'm not a computer scientist. I am a nurse practitioner in the pediatric urology division at Sick Kids, and I am by no means an expert in artificial intelligence or machine learning. But while I'm not an expert, I have completed a 2-year certificate course in machine learning in healthcare, which was helpful in learning the basics of this technology, including some coding and Python language. It was also very useful for ensuring that I could bring some clinical and machine learning understanding to the larger team that I work with. And so these are a few of my key collaborators from both clinical and machine learning aspects, and together we have integrated machine learning technology into peds urology clinical practice, particularly with respect to congenital kidney abnormalities. While other groups have explored machine learning conditions in urology, like hypospadias, I will focus primarily on our work for examples of machine learning projects in this talk. So the objectives of my talk today will be to review some machine learning fundamentals, to discuss the ethical implications of machine learning in healthcare research, to see some real-world demonstrations of AI-based models incorporated into clinical practice, and to showcase some new technologies and future direction of where all of this technology is going to be going. So to start off, what exactly is artificial intelligence? Well, this refers to a program developed to perform tasks that would normally require some human intelligence. Within AI, you have the domain of machine learning, where models can learn from data over time. And even more complex than this is deep learning, which is a form of machine learning that's designed to work like the neurons of a human brain. And so artificial intelligence, it's not a new concept. We interact with AI every day when we browse social media, when we buy things online, or we interact with virtual assistants like Alexa or Siri. As most of you realize, AI is how these companies read our minds and place ads and remind us of what we were only thinking of buying earlier that day. So let's move on to an area that we're all familiar with, and this is how machine learning is being used in healthcare and in pediatric urology specifically. My team started exploring machine learning technology back in 2017 because we were interested in predictive analytics. And at that time, Microsoft Azure was a new cloud-based, easy to learn, and importantly, free tool that could be used for this type of research. And so within the Azure space, we used our institutional hydronephrosis database to design a model to predict which kids were most likely to go on to surgery. And so this was very easy to use. You would simply drop your data set in, and this would help us prepare the data. You would tell it how you wanted to split your data set into testing and training. You would pick the type of model that you wanted to use, and this then would automatically train, score, and compare those models for you. And what this algorithm showed is that there was an excellent area under the curve of 0.9, and the accuracy was 0.87. And the major benefit of this type of technology is that it was free, easily available, and extremely fast. And so the average time that it takes to perform all of these tasks is about 5 seconds, which is very impressive when you consider that it takes hours to do this using traditional statistical software. And so this early exercise in machine learning resulted in our first paper on this topic in 2019. Since then, the use of machine learning technologies in peds urology has multiplied. And in fact, more and more machine learning algorithms are coming down the pipeline than ever before. We recently published this paper demonstrating the exponential rise in the quantity of machine learning algorithms over the last 25 years. And now we're starting to see models in a number of different pediatric urology domains, as opposed to congenital kidney anomalies, which is what we tend to focus on the most. And so because of this wide uptake of this technology, we proposed a framework of reporting of machine learning research in urology. Stream Uro offers suggestions about standardized reporting of AI-based urology models, similarly to PRISMA guidelines and consort guidelines for other types of traditional research. And so just as we can see from the last paper I showed you about the steep increase in machine learning publications over recent years, this type of work is also being endorsed by institutions who see this as important for personalized medicine. In fact, the new Sick Kids campaign is called Heal the Future, which is centered on personalized medicine. And this is also a core part of the 2025 strategic plan at Sick Kids. And so the work I'll present to you today ties into this plan and campaign and our institutional values. So now we can talk about something that we're probably already familiar with. Hydronephrosis is the most common congenital anomaly that's detected prenatally, and it occurs in up to 1 to 5% of pregnancies. Because it's so common, it represents about 15 to 30% of our clinic volumes. And as most of you know, hydronephrosis is not an illness or a disease, but instead it's a finding on ultrasound. The natural history of hydronephrosis varies from self-resolving or transient to obstructive hydronephrosis that might benefit from a surgical intervention. So approximately 80% of hydronephrosis is transient and self-resolving, and the remainder is comprised of UPJ obstruction, UVJ obstruction, or reflux. And while it could be caused by congenital anomalies such as posterior urethral valves, for the purpose of most of our projects to date, we have focused on infants less than 2 years of age at baseline with no other congenital anomalies. So when we consider the goals of hydronephrosis management, ultimately, we want to prevent deterioration of renal function. We want to be able to identify kids who need close follow-up compared to those who can be watched conservatively. We want to minimize parent anxiety, and we want to reduce invasive tests for many who probably don't even need them. And so there are guidelines available that can help our decision-making for hydronephrosis. This one is from the 2018 Canadian Urological Association. And in this guideline, it suggests that all children with SFU grade 3 or 4 should be given prophylaxis. They should be investigated with a VCUG. And if it's negative and the hydronephrosis is persistently high grade, then they should be investigated with a renal scan. The drawback to these types of guidelines is that it offers a one-size-fits-all approach and results in very invasive monitoring for this condition, despite the fact that most of these kids will spontaneously improve on their own. And so this is what hydronephrosis management looks like at our institution. So it's detected prenatally in a lot of cases, and it's monitored with repeated ultrasounds based on the severity of the dilatation that we're seeing. And some of these kids, if they develop symptoms or the hydronephrosis is severe, will need invasive tests like renal scans and VCUG. And approximately 20% of these will progress to surgery at some point. It is important to note that less than half of kids who are investigated with a nuclear scan at our institution actually go on to surgery. So despite having a good understanding of management goals, deciding between surgical intervention and monitoring remains a common challenge and a controversial topic within the peds urology world. Identifying patients that would benefit from surgery is certainly not always possible upfront or with early ultrasound images. So due to the invasiveness of hydronephrosis monitoring and the large number of kids investigated with invasive tests, risk stratification by ultrasound images is very appealing. So what do we already know about ultrasound? Well, the limitations of ultrasound is that they're operator dependent and provide us no information about function or drainage time, the presence of reflux or cortical scarring. Advantages of ultrasound, though, is that they're non-invasive, they're well tolerated, they're widely available, and importantly, they don't incur any radiation. And so we believe that there is more information embedded in ultrasound images that can't be recognized or appreciated by human interpretation, and that there could be valuable information in the metadata of renal ultrasound pictures. So when we look at ultrasound images like this one, we're often limited by our subjective assessment of the appearance of that image. We can describe the parenchymal characteristics and assign a hydronephrosis grade, but poor reliability has been shown between raters when doing so. If we compare this to a renal biopsy core, Looking at this on the surface, we can describe the shape and size of the tissue, but when we put it under the microscope and apply new stains and different microscopy techniques, we're able to make a true diagnosis, and this is the metadata that's embedded into the biopsy tissue. And so how can we apply the same type of thinking to a kidney ultrasound image? And how can we pull out the more important information that's beyond the subjective interpretation? And that's where machine learning can come into play. And so this is what fueled our hypothesis when we started this project over 5 years ago. And it's that there's information embedded in ultrasound images that can be used to predict outcomes, and that this can be optimized with artificial intelligence. So these are the steps for building our hydronephrosis model. So we looked at our hydronephrosis database. We pulled out all of the kids who are less than 2 years of age at baseline. We included isolated hydronephrosis and Megarder patients, and we included all SFU grades. We excluded people with other urinary tract abnormalities, which resulted in almost 300 kids being included. The data was split into 70% training and 30% validation. And what we wanted to predict was a hydronephrosis severity index score. And so what are convolutional neural networks? So these are a form of deep learning. Many layers or neurons are modeled on the understanding of the human brain. These models are very effective at image recognition. Each convolutional neural network contains 4 major steps, which I'll explain in the upcoming slides, including convolution, nonlinearity, activation functions, pooling, and subsampling and classification. Oops. So as the concept of CNNs are based on the human brain, they also have something called translational invariance, which means that they can learn an object and then they'll be able to recognize it anywhere in the images. For example, once a model is trained that this is a dog or this is my dog, Harry, it will recognize him regardless of the environment, color, or position of Harry in the images, just like a human would be able to do. And so when we're using convolutional neural networks for image classification, it occurs on a pixel level where a filter is passed over the image and patterns are identified. And the example on this slide, each number in the orange table represents a pixel, and the green table is the filter. Filters are used because they're helpful in identifying features such as edges and corners. The filter is passed over the image, and a mathematical operation or convolution is carried out between the pixel value and filter to produce a matrix summary as the result. So images are passed through each layer, and a report for the likelihood of outcomes of interest is produced. Our model consists of 7 layers, and for each layer the image passes through, the important features are extracted and are passed through to the next level, which is what this diagram is showing you guys. So our model is a Siamese model, which is used because we wanted to include 2 ultrasound views for predictions with the same filter for each image. After the image has been passed through all 7 layers and we have our result, it's flattened in order for it to be combined. And that means that we combine the sagittal and transverse view into a single number. Concatenation refers to the process of combining data from both views into a single report. And this is repeated for both the left and right kidneys, and that's how we get our prediction. So in determining how well our model performed, we compared it to other well-known forms of convolutional neural networks, and we also compared single views versus combined views, and we noted that the Siamese views perform better. And our obstruction model, which is the first model we developed, has a promising accuracy of 0.93. So previously, we reported that less than half the patients who underwent invasive testing actually went on to surgery, and this is where we see our model having the greatest impact on clinical practice. Our model has the potential impact to allow monitoring for ultrasound alone for those who are at low risk of surgery, and expediting surgery for the kids who are most likely to need it. And while this sounds promising, how do we know that we can believe this prediction? So I'm sure most of you are familiar with what's called the black box effect. This refers to the uncertainty with what's happening in the hidden layers of a model. We see what goes into the model and we see what comes out, but we have no idea how this output is generated. And this might result in apprehension in trusting the prediction generated by the model. So ensuring explainability and transparency in algorithm predictions is important, especially for those that might influence healthcare decision-making and patient care. And so how do we know we can trust our model? One way is that we improved explainability is to generate these heat maps, which are overlays that the model produces based on the image that we have put into the model. And so this is telling us the areas of the picture that the model is using to make the prediction. And as clinicians, we can look at this and realize that this makes sense. And so this is using the hydronephrosis area and the parenchymal area to make its prediction for the probability of obstruction. And then it's also telling us the areas that it's deemed low importance for those predictions. And so why does all of this matter? Well, hydronephrosis is a very common condition, and parents want to know up front how their kids are going to do. And more importantly, because our interactions have long-term implications and we're born with a finite amount of renal reserve, it makes identification of kidneys that could benefit from timely surgical intervention important for the preservation of the renal function that these kids have. So now that we seem to have a working model, what should come next when considering the artificial intelligence research pipeline? And so our institution has developed an AI-specific panel for reviewing all of these studies that are being proposed at Sick Kids. It involves these 3 steps. The sandbox refers to the development of an imaging repository for exploratory development of a model. Step 2 is a silent trial where the algorithm is being tested prospectively, but behind the scenes, so it has no impact on patient care. And then this is followed by a clinical trial, which is the type of traditional research that you would expect. After developing the model, we had to test it prospectively, and we did this with silent trial methodology, like I just showed you. And so the next steps for our hydronephrosis model is a clinical trial, which is something that we're actively working on now. And so now we can go through some examples of some other types of models that we've developed in our clinic and with our hydronephrosis patients. So here's an example of a model that we developed to identify those at risk for recurrent obstruction after pyeloplasty. So we know that about 5% of kids after pyeloplasty will require a redo surgery. And we wanted to know who will fail, but also when they're going to fail. So the data set that we used to build this model, 39 of 232 patients included in the survival model required a reintervention. Not surprisingly, we noted that larger APD at the second post-op ultrasound and anatomical variation like a duplex kidney or a horseshoe kidney were significant predictors of who would fail. And in addition to predicting which patients are going to fail, we can also predict when this is going to happen. And this model is able to predict a time to event outcomes, which is demonstrated by the diagram in the bottom right. And this is very unique because you can put in your own patient variables by going to our website here. And this offers personalized risk stratification for all of your pyeloplasty patients. And it provides them an individualized risk assessment score that can be used to help guide some of this clinical decision-making. Next, we have a tool that we developed to help us predict outcomes in kids with posterior urethral valves. And this study was a multi-center study between us and the Children's Hospital of Philadelphia. So here are the outcomes of interest were the development of chronic kidney disease, determining which kids are going to progress to need renal replacement therapy, but also who would benefit from clean intermittent catheterization, as well as, again, offering an estimate of when kids are going to reach these outcomes. And so we found that using machine learning for predicting these outcomes is feasible. This QR code takes you to this app where you can obtain individualized predictions for your own posterior urethral valves patients with readily available clinical characteristics that you can get from the patient chart or at each clinic visit when they come and see you guys. Finally, this is a tool developed by members of our team for automated grading of vesico-ureteral reflex. And again, this was a multi-center effort with many different sites, and these sites all provided data to help us build this Q-VUR model. So this model still does require some annotation from humans, but we highlight the UPJ, the UVJ, and we decide on the ureter tortuosity, and then the model can use this to determine the grade of reflux. So here we show you the parameters that the model will take in, and then by automatically performing these measurements, this model is telling us that this grade of reflux would be 4. And this model performs actually better than most clinical experts. And the clinical experts here were pediatric urology staff, nurse practitioners, residents, other trainees, as well as pediatric radiologists. So what we found is that standardization can improve reliability. Coming next is using this technology not to predict the grade of reflux, but also to predict outcomes associated with reflux. And this app can be accessed at this site if you guys want to try this yourselves. So I've demonstrated a few examples of the work that we've done, but what exactly is going to be coming next? So I'm sure most of you have heard about ChatGPT, and this is something that's actually been all over the news very recently. What is ChatGPT? And so this on the left-hand side of the screen is ChatGPT explaining to us what exactly it is. And so this is a large language model, which is becoming very popular in medicine these days. It is a generative pre-trained transformer, which has been trained on large amounts of data. So when it is asked a question, it can respond by predicting which text makes the most sense to come next. This version of ChatGPT is free, and it gives you unlimited queries. And all you have to do is go to the OpenAI website, and you can register and access this on all of your devices. The new form of ChatGPT, though, is a paid subscription with even more capacity and even more capabilities in terms of not just ability to interpret text, but also images. And so here we demonstrated the capability of recognizing imaging, specifically an operative note of a transplant, where it can accurately describe the procedure, including the fact that this was signed by likely the person who drew this picture. But you can see that in seconds, this can interpret a very complex operative note very effectively, and in essence, explain the steps of a surgery to anybody who would be interested in reading about that. A previous group used the previous version of ChatGPT to study for the USMLE, which is United States Medical Licensing Exam questions. And the model was actually able to answer the questions and to be able to pass the test. Some of those questions, though, do include images and figures, and the previous versions of ChatGPT were unable to assess images. So now that, as I just showed you, it is able to interpret imaging, we took the image-based questions from the same exam. We trained a GPT model with this data, and what we found is that now this model is able to not just pass the exam questions, but also pass the questions that rely on imaging interpretation to be able to do so. Another domain that we've recently looked at when it comes to the new ChatGPT is the ability to do systematic reviews and meta-analysis. So anybody who has done this kind of research understands the cumbersome nature of having to have 2 independent reviewers review all of the papers, extract the necessary data, and then use a different type of statistical software to generate these forest plots. And what we did here is take a very well-known systematic review from the New England Journal of Medicine. We gave the PDFs of the included studies to our GPT model. We asked it to extract all of the relevant clinical information and study outcomes and to export it in the form of a table. And this table that was produced was identical to the table that was in the published systematic review. And then we also asked that it generate the forest plots, which it was able to do, which was also identical. And so what this is telling us is that this technology is available to be used. And while we should interpret it with caution and not say that this can do a systematic review for us, it can certainly be used as a safety check to make sure that the human people who are performing these systematic reviews are accurately extracting the data that's necessary to be able to draw the conclusions. And so that now that we have access to all of this technology, what are some of the things that we need to consider when we're using it and when we're moving forward? So we need to be aware of bias in any machine learning work and keep in mind that there is serious risk of bias in every phase of machine learning research, from conceptualization, model development, testing, validation, and deployment. In order to ensure responsible machine learning use in medicine, researchers need to be aware of all types of bias and to control for this as much as possible. So the previous slide listed the numerous known types of machine learning bias. And as responsible machine learning researchers and clinicians, it is important to continue to be aware of potential new biases that can be introduced. This paper is in press at the New England Journal of Medicine AI edition. And so during our hydronephrosis model development, testing, and validation, I was exposed over and over again to inputs, which were ultrasound images, and the outputs, which were the predictions. And after several years of this, despite the model not having been tested in a clinical trial, I noticed a shift in my clinical practice, which reflects the model's predictions. This means that while training the model with images, the model was also training me, if you want to look at it that way, with the predictions, and resulted in a subconscious shift in clinical decision-making. Thankfully, this model has proven to be accurate and has been externally validated already, but when this phenomenon could occur with any model, if the same individuals are participating in all phases of a project, that could pose harm to patients. Therefore, we propose that induced belief or vision bias be considered when conducting machine learning research in medicine. The other thing that we need to consider is something called fairness, and that's the ethical principle of ensuring that AI systems and algorithms treat all individuals and groups fairly without bias. So the first step is avoiding bias, which can arise from biased training data or the algorithms themselves. For example, if the training data is predominantly from one demographic group, the model may not perform well for other groups, which leads to disparities in healthcare outcomes. We need to make sure that there's equitable representation, which means ensuring that the data used to train AI models represents the diversity of the patient population that would be using the model. This helps prevent underrepresentation or overrepresentation of certain groups, which could result in biased predictions. We need to ensure algorithmic transparency, which means that healthcare professionals and patients should have insights into how the AI system arrives at its decisions, which again goes back to that explainability point. There should be regular audits and monitoring, and this includes evaluating whether the system exhibits disparate impact on different demographic groups and taking corrective actions if these biases are identified. There should be inclusive design, and this involves considering the needs and characteristics of diverse users and populations from the very beginning of model development. And then finally, there should be ethical review and oversight, such as with the RAB, and these bodies can assess the potential ethical implications, biases, and societal impact of AI systems before any of them are actually deployed in healthcare settings. So to help ensure transparency in reporting, in addition to reporting guidelines I mentioned in the previous slide, we also recently published some guidelines to direct the use of large language models and chatbots within the pediatric urology world. And so after listening to all of this and seeing the opportunity, but also the potential for harm, it's important to remember where the focus should be. That we use this technology as a decision-making aid and not as a replacement for human intelligence. And this is known as augmented intelligence. And if it's done properly and responsibly, then this means that it can only benefit our patients and their families. So I thank you guys so much for your time and attention this morning. I hope that you enjoyed my talk, and I'm happy to answer any questions that you guys may have.
Hey, Mandy.
Thank you,
Derek
Mandy.
here.
So very good talk. And we planned on having written questions in the chat, but we can try if we're going to let Joanna, who's raised her hand or his hand, in. Do you have a question for Mandy?
Thank you. It's more of a comment. This is an excellent talk, very didactic. I've learned a lot. And I wanted to know if ESPU will make the talk available. I know that you were recording, and if Mandy would not mind, because it really serves as a guide for researchers starting on AI.
Sorry, was that a question for the nurses group or for Mandy?
No, it was a suggestion.
Okay. Could you repeat that, Joanna? Please?
Yeah, would be a suggestion to make the talk available for sharing, as I think it really works as a good guide for researchers or clinicians starting on AI.
Yeah. Okay. Thank you. We will certainly consider that. We have had some time issue problems here today with the time zones over the Atlantic. So we will think about how to make this talk available for those who aren't joining us now because of the time zone. So it will certainly be available in some way. Thank you, Joanna. We have a question from Eric. Can you take a bit more about running clinical trials with ML modes?
Hi, good morning, Eric. Thanks for the question. This is actually something that we're working on an institutional level. When it comes to actually clinically testing a machine learning model, the pipeline that I showed you guys in the slides, which suggests the sandbox, which is developing your imaging repository, followed by the silent trial, followed by the clinical trial. We actually proposed to the REB that there should be a step in between silent trial and clinical trial, which would be a pilot or a feasibility study. Because once you have a model that's been validated in a silent trial and shown to be effective, before this can be implemented in a clinical trial where people are interacting with this in clinic, the feasibility piece is important because you need to understand how the end users are going to be able to interact with this model, how this is interfering with the clinic flow, and more importantly, how patients and families feel about this technology being used in clinic. And so I think that one little step that we're considering before an actual clinical trial is to gather those feasibility pieces in order to make the clinical trial a success. And so we need to understand how families are going to feel about this technology being used. We need to understand how the clinic staff feel about having this extra step that's going to be involved with seeing patients. And then I think the other piece is that when we're planning a clinical trial for our model, it's not to see how this compares to human decision making. It's going to be to see how this will help or hinder clinical decision making. And so when you're seeing a patient the traditional way, what's your decision versus you see the patient the traditional way, but now you have exposure to this prediction that's suggesting that the child either, is very low risk for surgery or the child is very high risk for surgery. How is that changing your decision making? And so that goes back to the last slide I showed you with augmented decision making. So this is not intended to be a tool that's going to replace clinical decision making, but hopefully enhance clinical decision making. And so I think in being one of the first teams at our institution to be this far ahead in this pathway, I think that these are going to be important things to consider, which will also help guide how other people who is doing this type of research are able to conduct their clinical studies.
Thank you, Mandy. Eric also writes, Google's diabetic retinopathy tool didn't do that, and it didn't work very well in Thailand for that reason. Also, follow-up question 2, what would be an example of a primary outcome for your model in a trial?
So I think that's kind of what I hinted at in this paper that's coming out, Eric. One of the things that we noticed is that there was a significant reduction in the amount of nuclear scans that we're ordering for these tests, or that we're ordering for these kids. And this induced belief revision, or the model training me, in our situation is a beneficial thing because, you know, these tests are invasive and we've been able to significantly reduce the number of them with no obvious harm that we've noted to those kids. But, you know, if we had a model that didn't work, that we were that were being influenced by, then those reductions could result in harm to those patients. And so I think that the outcomes could be, you know, a reduction in nuclear scans. The other thing that we can look at is the number of ultrasounds before a child goes to surgery and the age at surgery. We wanted to look at that, and we weren't able to because of the pandemic and how that kind of delayed all of our surgical times anyway. I think that we could, moving forward, look at that. So kids who need surgery are getting surgery faster with less tests. And then the other thing we can look at is the number of kids who are being discharged with fewer ultrasounds than historically. And I think this has benefit for patients. This has benefits for the institution. This is going to save money. And kind of big picture for this model is not necessarily that, you know, this is something that we need as experts who deal with these kids every day, but this could be a tool that's available to people who don't have access to pediatric urologists or radiologists, who work in remote communities, that can use this as a risk stratification tool to identify which kids actually need to come to see a specialist.
Okay, thank you, Mandy, again. Any other questions from the audience? Do you know if there's other centers doing this kind of research on the same topics as you are in the world or anywhere else?
I'm not sure that other people are necessarily doing, you know, work with congenital kidney anomalies. I know, like from the slide that I showed you, the uptake in algorithms that are being produced in pediatric urology is just exponentially growing. And it's kind of more distributed between kind of all fields. And I know there's work that's being done in hypospadias. I know there's work that's being done in kidney transplant. I know there's work that's being done in other areas. But for people doing kind of the same thing that we're doing, which is risk stratification for hydronephrosis using machine learning, to my knowledge, we're the only group that's doing that.
Okay. Yeah. Okay. Is there any? I was thinking. I mean, the technology is moving really, really fast in this field. And is there any problems on the legislation about this area? Or have you come upon some obstacles in that way?
I think that I have the benefit of a very forward-thinking institution, and once the machine learning applications started to come out, they were very quick to develop this research pipeline that I showed you guys. They were very quick to make a separate part of the research ethics board that deals only with machine learning studies. And so I think that they realized that this was going to be something that was going to be kind of the way of the future, and put safety parameters in place to make sure that this was being governed responsibly, while at the same time not putting up roadblocks. So if you come to our committee with an idea, it's not a yes or no. It's to make sure that your protocol is safe. If it's not, working with those researchers to make sure that they modify it appropriately, and then making sure that they facilitate moving these projects forward. And so I think that, I'm not sure what happens in other institutions, but in terms of our institution, this is something that has been ongoing for years and something that was recognized as having great potential fairly early on. And so as a result, we've embraced that and encouraged this type of research. And it is part of the strategic plan of SickKids, and personalized medicine is only going to be achieved with this type of research. And so there are considerations that we all need to take when using this, like some of the biases that I talked about, and ensuring fairness, and recognizing that there could be inherent issues with this type of research. Recognizing them and adjusting for them is very important.
Yeah, I agree. Okay. In clinic, how is it? You showed us some apps that you have developed to enter. Is it that way you work with it, that you enter data, or is it some automated interpretations as well that you have built in machines and stuff, or is it just that you enter the data to the model?
Yeah, exactly. So as you're seeing a patient, you understand the variables that the model needs. You put those variables in, and then you kind of get the prediction real time. I think that when it comes to the clinical trial for our hydronephrosis prediction model, the silent trial, which was done behind the scenes, this was, a research assistant who was kind of doing this after the fact, or I was doing it after clinic because it wasn't supposed to be impacting patient care. But for that model, what will happen is that when you see the patient, you kind of go through the steps like you normally would, but then it's simply a screenshot of their ultrasound that's dropped into the model, and then you're given a prediction, and you as the clinician will have to kind of interpret that and use it to make your decision making.
Okay, I see. Ananda, you raised your hand, but you lowered it again.
Yeah, no, I'm here. Thank you again, Mandy, for your amazing presentation. I'm not into this topic yet. It's something new for me. But my question is, nowadays it's hard to keep the safety of the information. So in the point of view, how to legally reasons, I don't know, because I don't know if the world is prepared for the safety of this information. So when you put all this data on these and these applications or website, how it's possible to keep the safety of this information? I know sometimes we don't need to say that this information is from this patient. We can use codes and MRN, but you think it's from the point of view of security, it's possible?
I think so. So when you think about kind of the steps of the research, by the time you get to an application that someone can use in their clinic, that is kind of anonymous data that they're putting in there. When it comes to the data that we use to train and test the model, that's done within the confines of the hospital, right? So no patient-specific information is ever leaving the hospital. And so you have to look at it as being as secure as the data for any other type of research study. And so when you're developing these projects, the same as if you're doing a standard RCT, that patient information and that clinical information needs to be stored securely, and it would be no different with this type of research. And so by the time you're getting to a model that's deployed, the data that's going in there is anonymous. And so the data, for example, if you use our app, the information that you put in there, we don't keep that. That uses that data to make the prediction. And then the data doesn't belong to us. It's not being stored at SickKids, and it is anonymous. And so when it comes to privacy and confidentiality, I would say that doing this type of research should really be viewed the same as doing any other type of study.
Okay, we have a comment here from Sarah. She writes, very interesting talk. Thank you, Mandy. I've no knowledge of this type of work going on in the UK, and I think we would have too many policies or governance in the NHS. Well, that might be the case. Bike writes, how does the silent trial work concerning ethics? Do patients still need to give consent?
So the silent trial design is still technically like a retrospective chart review. This is something that's happening after the fact when patients have already finished. And so, we do have a process for gathering data within our prospective hydronephrosis database. And so because those predictions are not influencing patient care, then we don't necessarily need to get consent for them. But the next step moving forward, where we're going to be testing this in clinic, then for sure we need to gain consent from families when this model could potentially be influencing the decision making. But silent trial just means completely behind the scenes, no influence on patient care. We're not aware of the predictions at the time of seeing the patient, so it really has no impact on patient care.
Okay. Thank you. See if there's any other comment or yeah, a moment. Thank you, says Bike. Great. Yeah, I think if there's not any other, Eric has a question. Please, Eric.
Thanks, Mandy. I'll just ask one more question. Mandy, what sort of skills or upskilling or training do you need to do to get people in the urology clinic who've never used AI to actually be able to use your tool? Obviously, you feel comfortable uploading images, looking at grad cams, understand them. So yeah, just I guess talk a little bit about the training once the tool's ready to use, either for the clinical trial or for that stage before the clinical trial that you mentioned.
That's a good question, Eric. I think that, this is why it's important to do the feasibility piece before launching into a clinical trial, because it's only going to make that trial more successful. The type of training, I think we need to decide which providers are going to be interacting with the tool. And then it honestly is as simple as taking a screenshot of the picture and dropping it in. And I think part of interpreting this prediction that's coming out, as well as the grad cam, I think is part of what we need to understand as part of the feasibility training. And I think that it will be interesting to kind of stratify by degrees of expertise. So how does a resident interpret that versus a fellow versus a staff person? And I think that that's part of the feasibility data that we need to gather and kind of compare how decision-making changes. And so, a quick hypothesis would be that if you don't have a lot of experience in dealing with kids with hydronephrosis, the automation bias is that this model must be right. And so you would think that a person with limited experience, like a resident, for example, would be more inclined to change their plan of care compared to a very senior person who deals with these patients all the time. They may be less able to be influenced by that output. So that's something that we will need to consider as part of the feasibility data.
Okay. Have you got comments from patients regarding this and families? Are they know that you're using it?
Yeah, so we have surveyed some families about this topic, and it's really 50-50. Some people we absolutely do not want this used by our clinicians versus we think that this could be interesting, and of course it can only enhance your decision making. So I thought that more people would be in favor of that, but so far families, and this is without any context, this is not giving them a detailed breakdown of what this tool is, how this tool is being used. It's not replacing decision making. This is what do you know about artificial intelligence, and would you be open to having this used in clinic with your child? And so that's just a very kind of broad question. And this is actually something that the hospital as a whole is looking into. They have a task force of kids and adolescents, and these are questions that they pose to kids, but also to families. Like, what do you want us to know about your beliefs in using this technology when you come to the hospital? So this is something that is happening in our clinic, but also in the institution as a whole, because that's an important thing to consider when we talk about implementing these tools and deploying them in clinical practice.
Yeah. So you don't have any reasons now why they're turning it down?
Exactly. Yeah. So we need to, and that's part of this, pilot feasibility study, is to ask them specifically what would be their concerns or why they would be open to it, and to tell them about our model specifically.
Okay. Yeah, that's understand. I can understand that there's some fears involved because of the speed of the development, but yeah, it's very interesting to know what their opinions are and why they don't want to be used. Yeah.
Yeah, and I think also to take the opportunity to explain to them the rigorous steps that we go through before a model reaches the point of a clinical trial and possible deployment, that this model has already been tested many, many, many times at sick kids. It's gone through the silent trial, there's external validation. And so by the time it gets to a clinical trial phase, that model has already, in theory, been shown to be safe. And so I think it's important to tell them about that piece as well, not just, we have this tool, it's being used, kind of take it or leave it.
Yeah. Eric writes here, great, thanks. Those results would be very interesting. And I agree.
Yes.
Okay. So any other questions for Mandy? No, I think we have covered the area for now. I mean, obviously we will, I guess we will be aware of this more in the future, and we look forward to know more from your work in Toronto.
Excellent.
Yeah, and we have as I said earlier, we have had some mishaps of the time planning across the Atlantic. So we have a lot of people not showing up for that reasons, I guess. And we will take a discussion on how to make this talk available for them as well. Obviously, we want this to reach as many people as possible. And we will have a talk with you, Mandy, about how you want it to be.
Excellent.
Done. And so one last chance of having a question for Mandy. Otherwise, we close this session. And again, we're sorry for the time zone mishap. I believe it was like an hour later on the invite to the American continent. But yeah, something happened there.
Daylight savings time, probably.
Yeah, I guess so. Yeah, that was one of my fears when we booked this one, but yeah. Okay.
All right. Thank you, guys.
Thank you very much, everyone who participate. And as I said before, the ESPU Nurses Group members will have a certificate coming their way on the email. And hopefully we'll meet in person in Naples in April on the ESPU Congress. So yeah, thank you, everybody, and have a great weekend.
You too. Bye-bye.
Bye.